Good morning friends, today we are going to see the second part of sample collection and transport. So today our discussion will be on systemized collection. First we will talk about urinary tract infection. Urine sample. 70 to 80% of total sample portions is urine sample. Collection is done by passive universal containers. Firstly, the past urine of the day should be sent to the lab because it's the most important and concentrated. Hence it should be more suitable for culture, microscopy and biochemical analysis. Patients should be explained about midstream urine and clean catch technique specimen. Midstream urine. Patient passes and voids the first portion of the urine to flush the urethra and the midstream sample is collected. Patient should be given sterile, dry, wide neck, leak-proof container and request a 10 to 20 ml sample. For female patient, explain carefully about the washing the hands first and cleansing the area around the urethral opening with clean water and soap. Dry the area, then collect the urine with a white mouth container with the labia held up. For male patients, wash the hand before collecting the midstream urine sample with the purpose retracted. Patients with renal failure and young children should be not able to get that much amount of sample, so a few millimeters of urine is collected. Suprapubic sample. Urine must be aspirated from the bladder using a syringe with a needle introduced aseptically through the skin and the abdominal wall just above the pubis, that is the suprapubic stab. A non-invasive method of stimulating urine flow in a baby is by tapping above the pubis with 2 fingers at 1 hour after feed. 1 tap per second given for 1 minute. As an interval of 1 minute is allowed, then tapping is resumed in this cycle. If tuberculosis of the urinary tract is suspected, the first urine passed in the day, that is early morning urine, is the most suitable sample, and 3 samples are collected and sent to the laboratory where it is centrifuged and its deposited are examined for microscopic and cultural examination. In the investigation of urethritis and prostatitis, the initial flow of the urine rather than the midstream should be collected and examined. Transport of specimen. So after labeling the sample, deliver the specimen with a return time of sample collection as soon as possible and send it to the laboratory. When the immediate delivery is not possible, refrigerate the urine for around 4 to 6 degrees Celsius temperature. When a delay of more than 2 hours expected, add boric acid preservative to the urine. When the sample of urine is not treated and are delayed more than 5 hours to transfer to the laboratory, the doctor should be informed that the sample is discarded. For positive findings may be misleading. Measured amount of boric acid powder 0.1 gram per 10 ml of urine to preserve the specimen and mixed well. A simple way of measuring routine the boric acid used in a small narrow tube, that is the precipitant tube, marked to hold around 0.2 gram of the chemical should be kept. Boric acid has shown some inhibitory action to enterococci and pseudomonas strains. Urine for culture must not be preserved with bactericidal chemicals such as thymol, bleach, and hydrochloric acid, acetic acid, and chloroform. So, urine sample collection. Catheter patient should be taken and the catheter should be clamped at the bag end and freshly passed urine should be removed using a syringe. It is must that the catheter should be sterilized using alcohol swab. Never collect the urine from the urine bag. Mark the sample properly and send it to the laboratory. Next is respiratory tract infection. Collect the sample in case of respiratory tract infection poses a number of problems because there is enormous commensal flora that colonizes the respiratory tract. Therefore, the specimen collection is very crucial and special cases of viral infection of the respiratory tract should be taken note of. One had to avoid contamination of the urine. The respiratory tract is broadly classified into upper and lower respiratory. Upper respiratory tract infection. The commonest type of respiratory tract infection are the oropharynx, nasopharynx, and nasal cavity, causing sore throats, nasal discharge. The upper respiratory tract infection is mostly in wider and general infections such as the whooping cough and measles, infections of the mycoplasma pneumoniae, parainfluenza, influenza, adenovirus, and EBV. A wide range of serotypes of rhinovirus and enteric viruses may also produce localized upper or lower respiratory tract infection and symptoms. In most cases, the viral infection predominates, but it can also have potential bacterial pathogens commonly present in the nasopharynx, example pneumococci, Haemophilus influenzae, Staphylococcus aureus, and Streptococcus pyogenes. Throat swabs used for both bacteriological and virological examination. For bacteriological sampling, a plain albumine coated, charcoal coated cotton wool swab and exudate from the tonsil from the posterior pharyngeal wall should be used, and the sample should be collected from the inflammatory area bearing the exudate. The sample should be rubbed with rotation over one tonsillar area and the arch of the soft palate and the uvula. The swabs may be collected on direct smear and other further culture. An adequate view of the throat by good lighting and use of a disposable wooden spatula to pull outside the depressed area of the tongue should be used. The swab should be replaced in its tubes with care and not spoil the rim. If it cannot be delivered to the laboratory within 1 hour, place it in 4 degrees Celsius. Throat swabs for virological examination are collected in the same way, but the head is broken into a small vial of VTM with penicillin gentamicin for the virus examination, or with ampicillin only for mycoplasma pneumoniae. Haemophilus influenzae. In the throat, there are a large proportion of the adults and children. This finding of throat swab should be generally ignored. In young children, especially under the age of 4, it may cause pharyngitis, tracheolaryngobronchitis, that is COOP, bronchopneumonia, bacteremia, and meningitis. And in such cases, it should be sought that the throat swab culture should be done. In children with suspected bronchitis and pneumonia, difficult to obtain satisfactory specimen of sputum and can be taken to throat swab or nasopharyngeal aspirate. In many cases, what is happening is it is difficult and hazardous to collect the throat swab from the children with the largest stridor, in which the attempt cases should be made by using the blood sample. For diphtheria specimen, take 2 throat swabs containing the fibrinous exudate and pseudomembrane. If nose or skin infection specimen are also taken from the. So, a gist. For upper respiratory tract infection, the container should be a swab moistened with straws or anis media. Collection of oral swab must be done by the removal of oral secretions and debris from the surface of the lesion and swab, and discard using 2 ml swab vigorously. The specimen from the lesion should be taken, avoiding any normal tissue. Nasal swab. Use swab moistened with sterile saline. Insert approximately 2 cm into the nares. Rotate the swab gently against the nasopharyngeal swabs. So nasopharyngeal swabs, when you have to collect the nasopharyngeal swabs, the nasopharyngeal cells and the mucus is removed. Small flexible nasopharyngeal swab or perinasal swab is inserted along the nasal septum to the posterior pharynx in the charcoal containing tube from the diagnostic of whooping cough. Rotate it slowly for 5 seconds against the mucosal for several times. Aspiration. It is collected by plastic tube attached to the 10 ml syringe with the suction catheter. Washing. It is obtained by the rubber suction bulb by instilling and withdrawing 3 to 7 ml of buffer saline. A suitable perinasal swab kit with Amy's charcoal transfer is produced in a medical wire. Laryngeal swab. Before use of swab, it is moist using sterile water. Patient is made to sit and hold the tongue fully protruded with the help of a piece of gauze. Pass the swab back through the mouth via midline and downward over the epiglottis and to the larynx, where it should be induce reflex coughing, that is helping in expulsion of the sputum into the swab. Withdraw the swab and replace it tube and deliver it to the laboratory. Throat swab. Depress the tongue with tongue depressor. Induce the swab between the tonsillar pillars and between the uvula without touching the lateral walls of the buccal cavity. Swab back and forth across the posterior pharynx. Any exudate or membrane should be taken as specimen. Transport should be done within 24 hours after collection. Sputum. The material from the lower respiratory tract infection is mostly submitted for bacteriological examination of this sputum. It contains a mixture of bronchial secretion and inflammatory exudates cuffed up into the mouth and expectorantly. Sputum appearance: purulent, green-looking, moistly pus. Mucopurulent, green-looking with pus and mucus. Mucoid, mostly mucus. Mucosalivary, mucus with small amount of saliva. When the sputum contains blood, it should also be reported. Many patients tend to swallow the sputum when it is cuffed into the throat, and when asked to spit out something, It is mainly the saliva. Saliva can be recognized by a relatively clear and watery rather than viscous. So instruction to collect the sputum: container should be disposable wide mouth screw cap plastic container around 100 milliliter capacity. Ask patient to brush the teeth and rinse or gargle with water before collection. Collect the sample before antibiotic the first day in the morning. It is difficult in coughing is seen. Sputum, then postural drainage and physiotherapy can be given to stimulate coughing. Delivered within 2 hours because mycoplasma and other biofilms does not live longer. Caution must be taken when transportation of sample and collection is done to avoid spillage. Transtracheal aspirate. So obtained by inserting a small plastic catheter into the trachea through a needle previously inserted through the skin and cricothyroid membrane. This technique is rarely used nowadays. So next is pleural fluid. So pleural fluid, pericardia, peritoneum and synovial fluids. The container should be sterile capped. So patient preparation here is you have to disinfect the skin before aspirating with 2% iodine tincture. So collection is done by percutaneous needle aspiration or surgery. Transportation is immediately at room. So the procedure is after aspiration of the site, aseptic dispensed into the fluid in 3 to 5 ml of dry screw cap container, and the bottle should be observed for clotting. For transportation, dispense 5 ml of the bottle of sterile thiocalcium broth and mix 9 ml into the screw cap container or bottle containing 1 ml of syringe trisodium citrate, which mix the fluid with the anticoagulant. Trisodium citrate prevents clotting, especially for exudates. Send the sample with completed request to the laboratory within few hours. The inoculum containing thioglycerol broth should be kept at warm environment but not over 37 degrees in direct sun. Next is blood. So blood culture media, aerobic and aerobic media with SPS are used. Caution should be taken before using blood bottles. Always check if the signs of contamination, oxidation or right amount of media quantity is present. Then use of pressure cuff for suitable vein, arm disinfection and venipuncture state should be done for 70% ethanol. Then 2% tincture iodine in circular motion should be applied. Allow it to dry for 1 minute. Avoid touching venipuncture sites and immediately take out the blood and insert the whole cap. So blood for adults should be around 5 to 10 ml. For pediatrics should be 2 to 3 ml. It should be taken at 2 set aerobic and anaerobic bottles at the onset of 24 hours after the patient has been admitted. It must be taken before administration of antimicrobial agents. The blood injection by insertion of the cylinder needle into the hole of cap should be slow or it may lead to hemolysis. And through the central rubber or plastic container, the cap must not be removed for induction of the blood. GI tract. Fecal specimens. So around 25 ml of specimen is collected in a clean leak-proof container. So how to collect it? Pass the stool directly into the sterile wide mouth container, leak-proof, and it should be containing a spoon with it. Collect 1 to 2 ml of stool in the spoon. Pass the stool into clean dry bedpan and transfer it into a sterile leak-proof container with a tight fitting lid. Stool for over parasite should be placed in a preservative immediately after collection. So transport should be around 24 hours at 4 degrees Celsius. If delay is unavoidable, particularly when the weather is warm, collect the specimen in a container, put 6 ml of glycerol buffer saline transport media. So some of the transport media which we can use are Gary Blaze for enteric organisms, Schwartz for all enteric organisms, Amis media for enteric organisms, buffer glycerol saline for for enteric organisms except Vibrio and Campylobacter, alkaline peptide water and VR medium, that is Venkatrama Ramakrishnan medium for Vibrios are used. Rectal swab, my HOD's favorite. So the swab is placed in enteric transport media. So collection is by passing the tip of a sterile swab approximately 1 inch between the anal sphincter. So carefully rotate the swab to sample the anal scripts and withdraw the swab. Place it in a transport media. Transport should be done at 40 degrees within 24 hours. Duodenal aspirates. Container should be sterile screw cap container. Patient preparation: collect as early as possible before the patient eats and gets out of bed. Ask the patient to swallow a weight gelatin capsule containing tight one length of string which is protruded from the mouth and taped in the cheek after a predetermined period, during which the capsule reaches the duodenum and dissolves. The string now covered with the duodenal contents is retracted, transported as soon as possible. Genital infections. For genital infections, confidentiality is important and case reports, whether positive or negative, on the result of examination of sexually transmitted infections and HIV infections and hepatitis B infections. Such infections should be posted separately and directly told to the physician in charge of the patient's case, and the use of code numbers rather than names merits serious consideration. Female specimen. Specimen collected from the diagnosis of vaginitis, vaginosis, uterine sepsis is a high vaginal swab. So the swab is inserted in the upper part of the vagina and rotated before withdrawing, so the exudate is collected in the upper part of as well as the lower vaginal wall. If gonococci is suspected, so the delivered from the infected cervix tend to die off, and the acid fluid, if remains viable, are likely to be overgrown with irregular commensals. An endocervical swab should be collected for examination for gonococci with use of vaginal speculum, and swab is rubbed around the interstices of the cervix and withdrawn without contamination from the vaginal wall. Other swabs that can be used for exudate discharge from the meatus of the urethra or a bathroom gland. Rectal and pharyngeal swabs should also be considered. Swabs for culture should be placed in tubes of Amy's transport media and delivered to the laboratory. 2 swabs can be taken and submitted from each side, and one for making clips and another for seeding cultures. For examination of trichomonas, a swab placed in the trichomonas transport medium for microscopy and possibly a culture should be done. Container should have moistened swabs with Schwartz and Amy's media or jam-packed medium for gonococci. Collection of swabs and secretions and mucous membrane of vagina should be done. Transport within 24 hours. Genital tract infections in male. In urethritis, urethral discharge is collected in interloculated tubes and should be inoculated immediately on warm plates of heated blood agar and selective media for culture of gonococci. To transport the laboratory, as much as exudate as possible should be collected on a swab, and the swab once plunged into the Amy's transport media. When prostatitis is suspected, there is no spontaneous discharge from the urethra. Massage the prostate as per rectum and may express some exudates for examination. A specimen of clotted venous blood should be collected for serological examination. Containers which are used are swabs moistened with Schwartz, Amy's media or jam-packed medium. Collection is done by using cleaned cleanse penis with soap and water. Collect the secretions of the swab in tubes. Transport within 24 hours if swabs and immediately for the soft tissue infection. So soft tissue infection may be endogenous or exogenous. So pus exudates. A small screw cap container containing a firmly stoppable rubber syringe or a sterile capillary tube. Pus in oxygen-free medium. Gassed out vitals, or in special cases where transport media is suitable. The routine use of transport media in swab case with delayed transit is required. Fragments of excess tissue removed from the wound, toilet or curating from the infected sinuses and other tissues should be sent in a sterile container without fixating. Delay must be avoided, and swabs containing the exudates may dry up, so use moist cotton. When using swabs, load the swabs well with the material. If possible, set 2 swabs taken from the depth of the wound or lesion so that they can be used for preparation of smears and for microscopy. Then the other sample can be used for seeding cultures. A dry swab must be first moistened in a little sterile container, then be separated. Superficial specimens. So the container used is anaerobic swab moistened with stewards or ABS media. Patient preparation is done by 70% alcohol wipes. Collection is a swab along with loading edge of wound and transport. So the container in condition where deep specimens are collected are anaerobic transport. So it is same. Here the collection is done by aspirating material from the wall or the excise tube. Transport is required. In case of eye infection, it is difficult to obtain adequate specimen from the sample because it's very delicate area, and the bacteria which is present in this area is also very delicate. To make best smears and seed cultures, plate beside the patient immediately and collect the sample from the eye because the volume of exudate is very slow. The dry cotton swab, which would absorb the retain most of the specimen, is unusable or unsuitable as it means of collection. The exudate should be picked up with a steel platinum loop or in a smooth rounded tip of thin glass or plastic rod, otherwise the tip of the serum coated swabs. It should be collected from the conjunctiva, for example from the underneath of the everted eyelid, and contamination from the skin and the margin of the eyelid should be. A separate collection should be made for inoculation onto the culture plate. It is necessary to displace the specimen to the laboratory before inoculation onto the culture media. It should be taken note that the albumin coated swab which is placed on storage media transport is used. So this is how this transportation and collection of conjunctival swabs are done. So for anaerobic culture, the container used is an aerobic swab containing stewards or AMIS media. Collection is done from the superior and inferior tarsal conjunctiva. Specimen from the both eyes with separate swabs by rolling is taken. If viral culture is required, a second sample is collected. For chlamydia culture, swabs are taken with a dry calcium alginate. Transport as usual is very important and should be done around 24 hours at room temperature. For viral culture, treated immediately using a culture media, that is you should transport it through the PTM. For chlamydia, place in 2SP transport medium. Corneal scrapings. So here the media which can be used are blood agar, chocolate agar, sabra dextrose agar, and thioglycolate broth. The 7H10 is what you uses. Okay, clinician should install local anesthetic before collection. By using heat sterilized platinum spatula or calcium alginate tip swabs, samples can be collected. It should be transported. Anterior chamber, vitreous chamber collections. Aspiration is carried out with a tuberculin syringe fitted with 25 to 27 gauge needle for aqueous and 21-20 gauge needle for vitreous aspiration. Transport done. For ear infection, in case of inner ear infection, sterile screw cap containers or tubes or aerobic and anaerobic transporter are required. Patient preparation is done by cleaning the ear canal with mild soap solution before function of the eardrum. Aspirate material should be behind the drum and the syringe should be behind it. So you have to aspirate if the drum is intact. Use swab to collect material if the rupture of the eardrum is seen. Transport is immediate. Rapid transportation is required in between. So for outer ear infections, the container is mostly aerobic swab moistened with stewards or AMIS medium. Patient preparation is done by wiping the crust or the sterile saline. Collection is done by firmly rotating swab in the outer canal and fungal specimens. For hair, nails, skin scrapings, hair. Infected hair should be removed by plucking or using an epilating forceps and never be cut because it fails to remove the area most likely to harbor the fungus, that is the base of the hair shaft around the follicle. The specimens which are collected contain species which are more frequently associated with scalp ringworm, causing the affected hair to fluorescate under a wood slump. Storage and transport of this can be done by using black paper method, and all three types of gelatinous material should be allowed to dry out, preventing the overgrowth of saprophytic bacteria and fungi in the airtight containers such as small glass bottles. Specimen should not be refrigerated. The swabs are unsuitable for dermatophytes. Sputum collection for fungus is you have to collect 3 samples for 3 days, or 8 to 8 hourly sample for 3 days, 3 times. So storage of 4 degrees Celsius to avoid over skin scrapings. Grossly contaminated skin should be cleaned thoroughly with 70% alcohol. A curved disposal scalpel blade, example Swan Morton's number 22, is used. If vesicles are present, the tops of the vesicles should be removed, and using a fine scissor, the sample should be sent for examination. Skin stipplings, alternate method for collection of skin specimens by applying waterproof transparent vinyl adhesive tape firmly affected area and peel it off. The tape bearing the thin layer of the skin is then applied on a sterile glass microscope and transported to the laboratory in a protective manner. So nails are friable material and should be removed under using the underboard of the nail, or clippings may be taken from the distal border of the scissors or nail clippers. When dystrophy does not extend to the distal part of the nail, the scraping should be taken using a scalpel blade by scraping across the affected area. In case of paranoia, that is yeast infection, exudate is expressed on the paranoial folds by probing with flat evacuator and collecting on the swab previously moistened with sterile. In case of CSF infection, minimal 5 ml of sample is recommended for Cryptococcus transport without delay. Swab should be heavily charged with exudate, pus and other specimens. Plaques area should be rubbed firmly in areas like mouth, throat, vagina. Survival of yeast and dry swab is inversely related to time and storage temperature. If delay is expected, store at 4 degrees, transport in trichomonas medium. Other specimens can be urine, blood, bone marrow, stool, tissue, pus and fluids. So here you can see that the container is a screw cap needle. Patient preparation is done by using 70% alcohol. So if it's a hair sample collected with the intact shaft, nail should be clipped, skin scraping at leading edge of the lesion should be done, transport immediately. In case of leprosy specimens, take 4 skin samples from the forehead, cheek, chin and buttock. Cheek, chin, buttock and forehead. One from the earlobe and the nasal mucosa by nasal blow or scraping. Slit skin here is used to collect from the earlobe specimen, tissue pulp from below the epidermis. Nasal specimens is collected by nasal blow. Early morning mucous material. Nasal scraping material should be done to scrape the nasal septum. Biopsies of the thick nerves and nodulation should be. So in case of parasitological specimens, all specimens should be collected in a suitable clean wide mouth container like a plastic container with a light fitting lid, waxed cardboard box and matchbox. All fresh samples should be handled carefully. The specimen should not be contaminated with water, urine or disinfectant. Liquid stool should be examined for immediately and should be preserved for 30 minutes after passage. Stop stool should be examined or preserved within 1 hour of passage. NIH and cellophane tape or scotch tape technique method is used to collect eggs in the perianal region. Sputum sample for Paragomonas westermani should be. If delay is expected, so here the fecal sample should be kept in room temperature, never be inoculated or frozen prior to microscopic examination. Molecular and some other assays of frozen specimens can be used. Preservatives like 10% formalin should be used to maintain the morphology of parasitic eggs and other specimens. For malaria, blood should be collected not during the peak of fever but optimally several hours after it. The emerging merozoites, parasites, the erythrocytes, and initiate the fresh cycle of erythrocyte seizure again. The time is particularly important for falciparum because here the late stages of the seizure is not seen in peripheral circulation. DEC provocation test is done by using 2 mg per kilogram of DEC per body weight and brings the microfilariae into the peripheral circulation. After that, you have to collect the blood around 20 to 50 minutes. So other specimens which can be used for parasites investigations are urine, blood, body fluids, CSF, duodenal aspirates and muscle biopsy. Tissue biopsies. Tissue biopsies of fine needle aspirations can be taken from cutaneous cells of trypanosomiasis and leishmaniasis, and from skin nodule for onchocerciasis and post-palazza dermal leishmaniasis, that is PKD. A skin snip can be obtained to diagnose subcutaneous filariasis or leishmaniasis by gasping using a forceps and elevating the portion of the skin with the tip of the needle. Tip of the small cone of the skin is laced with the sharp blade. Virological samples. The principle of the optimum selection of the specimen for diagnosis has 4 criteria. First is the virus staging of the disease. Second is variants, antigens, which are specific for nucleotide sequence at the lesion. The third one is the virus should be grown readily in the cell culture. The fourth is antibody response to the antigen in the suspected disease. And it is necessary to collect the paired sera or will measure the specific IgM antibody in a specific sample. Sample collection for the viruses can be taken in several forms using swabs, scrapings, aspirates, excreta, biopsy specimens, and for cytological examination, blood sample is obtained. Samples can be from the cervical or conjunctival swab, nasopharyngeal aspirates, stool, throat swab, urethral swabs, and vesicle. So transport is done by using cold chain at 4 degrees Celsius. If delayed more than 48 hours is expected, use -70 degrees, not -20. Understood? In case of hospital environment, take the specimen at night instructed to the place of containers of fridge rather than the freezer. Biosafety. So the surgical biopsy of mother foot should be sent to the laboratory immediately. The biopsy should be divided into 2 parts, one part for the grains and second part for the histopathological examination. The former placed in normal saline while the latter placed in 10% formalin saline. Mycetoma grains are crucial to establish diagnosis of positive organisms. Grains have different morphological features. The size varies from microscopic 1 to 2 mm in size. Madurella mycetomatus and Actinomycetoma have large grains, whereas Nocardia brasiliensis and Nocardia canvae and Nocardia asteroides have smaller grains. The color is variable, ranging from black, yellow, white, red, or pale. Most of the Eumycetoma causative organisms produce black or pale grains and rarely yellow. And Actinomycetoma causes grains which are yellow and white. So the sample collection is very important for laboratory diagnosis, directly affecting the patient care and patient outcome, influences therapeutic decisions, impacts hospital infection control, impacts patient lengths of stay in hospitals and cost and laboratory costs, influence laboratory efficacy. Thank you so much. I think this was a very large lecture. This lecture took so much of pain. I prepared these notes for 2 hours, then referred 20 books, spoke for 30 minutes. Now I think it will take 40 minutes for uploading. Thank you so much, friends. Hope you get benefited for free.